Good morning, everyone. Those who just joined, good morning, and hope you enjoying your weekend so far. It's 10:59 a.m. So I think most of you have already had breakfast. If not, just get yourself a cup of coffee and something to munch on while enjoying the webinar. Okay, as we are still waiting for more to join us, I think we shall wait for another 5 minutes. Is that okay, Doctor? Okay, we can see that's more people coming in. So hello to those who just joined, and yep, we are just warming up and waiting for the rest to join us. So let's wait for another 5 minutes. We will start at 11:05. Doctor, at the meantime, I think you can start sharing your screen and perhaps do some testing.
Yeah, sure. I'll just share my first slide then. Okay, I think that should be fine.
Yep, it's visible from my side. Yeah, I can see that's more people coming in. Hello and good morning. Happy weekend. You have made it to another week. Hope you have had a productive week. And how about you, Doctor? How's your week so far? Is that busy?
Yeah, slightly busy. But yeah, I think a Saturday morning is quite a good time to relax, not do patient, and just give a talk. So quite excited to share my experiences. Sorry, am I audible or?
Yeah. Loud and clear.
Great.
So let's wait for another 2 minutes. Okay.
Sure.
Have you had your breakfast, Doctor?
Yeah. Actually, I woke up around 9 and just had breakfast, coffee, and just have a look at my slides.
Yeah, coffee is a must in the morning.
Yeah, definitely. How about you?
I had McDonald's.
Okay. It's a very good breakfast.
Okay, it is 11:05. So for those who join late, we will just proceed first. Okay. And yep. For your information, this session will be recorded and the chat box is open for questions throughout the webinar. So please feel free to ask by typing in your question in the chat box. You may send in your question at any time during the presentations, and we will address this question one by one during the Q&A session after the presentations. I am Kirshen, the moderators of today's webinar, alongside my batchmate, Ms. Kritika. Today, we are very honored to have with us Dr. Bryant, a proud PIDC graduate who has achieved many accomplishments. My colleague, Ms. Kritika, will be taking over and give a complete introduction of the speaker.
Good day, guys. Welcome to Dr. Brian Chong Wang Hong, our very own alumni, for today's webinar on prosthodontics behind the smile. In 2014, Dr. Brian finished his BDS study at Penang International Dental College. From 2018 to 2021, Dr. Brian continued his dental education as a postgraduate student, specializing in prosthodontics at Edinburgh Dental Institute. Dr. Brian has completed advanced training in the field of prosthodontics, which involves dental material sciences, case planning, and treatment using traditional and digital prosthodontic procedures. Having strong affection for PIDC, Dr. Brian served as President of Student Council of Penang International Dental College in the year 2013. In addition, from 2019 to 2021, he also served as the President of the Alumni of Penang International Dental College. Now, Dr. Brian will be sharing with us about prosthodontics, especially the requirements to specialize in this field, also his experiences, career prospects, and many more. So stay tuned, guys. And again, Prosthodontics Behind the Smile by Dr. Brian Chong Wang Hong. Doctor, the floor is yours now.
Okay, thanks, Katika and Kishan. So first of all, good morning, everyone. It's a very good introduction by Katika. So I'm just Brian Chong, and let's just start with this presentation. So today's topic will be about prosthodontics behind the smile. This was a topic that was suggested by the chairperson and the committee behind this webinar. And we'll be talking about what does a pros do and how do I work, basically. So just a brief introduction. I'm just going to talk about prosthodontics and what does a prosthodontics do. I'm quite sure that everyone knows what prosthodontics is. It's just part of a dental specialty that pertains to the diagnosis, treatment planning, rehabilitation of the oral cavity, and it's going to provide a better function, comfort, and appearance for the patient as well. While you always replace the missing teeth or any pathological things that are causing problems to the patient. So that's just a very brief introduction on prosthodontics, and I'm quite sure everyone knows about that. Just need to reinforce on that. And I'm going to talk about what mainly does a prosthodontist do, because we can always see most of the treatment that I do or a prosthodontist do is actually quite similar to what a general dentist do. I mean, we do crowns, we do dentures, we do fillings just to try to restore function of a certain teeth. What I understand after going through my postgrad training is that process to cases that are more complex, and it's about how to determine the current situation of the patient, or maybe the clinical appearance of the patient, and how can we do that to prevent it from getting worse. So that is one of the main differences I found out in general practitioner work and pros work. So enough of that. We can just talk about what's my experience I did in Edinburgh. So on the picture on the upper left side, so use my pointer here. You can see this. This is actually a picture in my graduation hall. It's actually a dome-shaped kind of building, and that is the ceiling inside. So it's a really classical architecture, and I found it to be really interesting when I first entered the hall. And as you can see, there's little pictures around here that actually represents all the different departments in the University of Edinburgh. And it actually shows, like, in a very classic Romany way of how education has evolved and how this careers has been evolved since then. In the picture below, you can see that's the Edinburgh Castle. It's taken from the Princess View Gardens. It's very a beautiful place, and anyone that goes to Edinburgh will say it's a very beautiful place, and I would suggest everyone to go there just for a holiday if you can. The weather is not good. It's always cold. It's always below, I think the average temperature throughout the year is around 8 to 10 degrees. So it's a nice cold weather compared to Malaysia. So enough of my experience in Edinburgh. Let's get to what this topic is about. So just the flow of my talk, I'll be talking about, these are the contents of it. I'm going to talk about 3 cases mainly, just to discuss on how prosthodontists work and how we plan for the treatment. So the contents are, first, this is very important, and I'm going to emphasize just a bit briefly about it, is assessment and diagnosis. I like to divide it into 2 parts. One is from the patient's point of view, where we gather information from the patient and to see what the patient wants, etc. And I'll go in more detail in the next slide and while we're discussing about the first case. Next will be the clinical assessment. This is the data that we can collect, what we see, and what can we conclude from the current patient's situation that is showing to us. And from that, all the information, I can come down to a diagnosis. And that diagnosis will help in the next point, in the treatment planning. So for treatment planning, it's slightly a bit more complex. That's more towards the dentist's work and how we're going to apply our knowledge to help the patient. So to start to have a rough idea on how to proceed, what are the more information that we need so they can work outside from the patient to have a nice plan. So with all the information, we can do the analysis and we can start our treatment planning. And from the treatment planning, we can come up with different options based on what are the considerations are. And after having a talk and discussion with the patient, we can come down to the treatment. The only difference that I noticed in prosthodontic work is we are trained to do organizing the treatment process or the sequelae of the treatment, because it's not only a single appointment, it's multiple appointments to achieve the patient's expectation. And then that actually goes down to the next point where it's actually going to the management of the patient expectation. And then we just come down to a summary and conclusion of all the cases. So we're just going to move forward to the first case. I'm going to go to more detail about the assessment diagnosis, So there are basically 2 types, like I said before. What I like to divide is to the patient and the clinical findings. So for the patient, what we normally have to do is we're going to have like a conversation with the patient. We're going to introduce ourselves, create a little rapport or relationship with the patient so they can actually create a trust or a bond between the patient within us. And then when you start chatting with the patient, you will ask about the complaints, any other symptoms they're experiencing, and what the patient expects from treatment. But before even having a long conversation about that, if the patient is in pain, you have to start the emergency treatment first and try to relieve the pain, either by giving other painkillers or doing like something to reduce the pain, because you can't really chat to the patient when they're in pain and or having agony, right? And then when that is settled out, you can go towards the clinical findings. in a brief kind of way of explaining this, I think most of us will know this. It's actually a general view of the oral cavity, where we have assessment of the soft tissue and hard tissue, where we do our dental charting, we do our periodontal charting, we do the current condition of each singular teeth, the number of teeth present in the mouth. And besides that, we're going to have a general view of the patient as well. We just not only have to focus on the teeth, we have to focus on the general view of the patient, how they're moving, how their current medical condition is as well. In particular, a good example would be patients with Alzheimer's or Parkinson. You can't really chat to them in Alzheimer's because they currently forget quite a lot of things. And for Parkinson's disease, you can see their hands a bit flapping and shaking as well. So from that view, you can come down to a general view of how the patient might be during the whole treatment plan. And then just in more detail about the diagnosis, with all the information that we gathered, with all the further investigations like radiographs or endodontic assessment, we can come down to a list of diagnoses. I didn't list it right here, but the first thing that you should list down if the patient is in pain will be the emergency kind of diagnosis. And that will be the first, and then come down to more of a subjective kind of view where it's asymptomatic. You can come to the periodontal, endodontic, prosthodontic, orthodontic treatment, diagnosis. And lastly, I just put down the oral medicine there if you found any abnormalities to soft tissue and hard tissue. So enough of that, just keep a rough idea of what I've explained briefly here, and then we can start with our first case. This is the first case I've seen in Edinburgh while I was doing my training. This is an extra oral view of the patient's smile, which I can see a general face view and a close-up view of the smile. So since we cannot have the examination of the patient, I'm just going to give a brief history about this patient. She is quite a young patient, 21-year-old female that was referred from orthodontic because she didn't like the appearance of the smile and the teeth. So after having a chat with her, I understand that she went through quite a lot of dental treatment when she was younger. She did have a fall when she was around 17 or 16 years old. And then she did a white filling on the 2-1 teeth. As you can see there, there's a slight discolorization and a little filling there as well. And you can see that she doesn't like her smile as well. And I just venture or ask her more what she doesn't like about it. So she was telling me that there's little gaps in between the teeth that she doesn't like. And most of her friends after orthodontic treatment will have the spaces closed up regarding that. And after that, I just asked about a medical condition as well to see that she has any other problems. Because the first thing that I noticed while chatting with her is I noticed that maybe she has a little smaller lateral teeth. So I suspected maybe she has a packed laterals or a smaller appearance of her lateral teeth. And I asked her, because it's a generic kind of more disease, a pathological finding that is more related to genetics. I asked her whether her siblings or her mom has this kind of condition where the teeth appears a bit smaller. So one view that I'm trying to point out in this thing is that we cannot look at the patient as a singular kind of problem. We need to look at the general point of view and try to assess all of family members as well, in this case of packed laterals. So as dentists, we're not only supposed to find out the patient's point of view, you need to find out in the general, in a holistic kind of way, where you must understand the patient, where they're coming from, why they're having this problem. Okay, so after having that chat and understanding all the history about that, I went on to talk about what can we improve for her if she wants, what does she want from after treatment. So she just tell me she wants to better appearance of her teeth. She wants to make her smile more uniform because she's going to college soon and she wants to look a bit better. Her high school days wasn't that happy because she got teased about her teeth. That was not uniform and a bit slightly, I would say the appearance is not that good to her. This is very important because from judging the patient's point of view on how they perceive their own appearance. To me, it actually looks quite all right. maybe just a little two gaps, I can accept that if that's in my mouth. But we need to understand each patient's condition and how they perceive that. So to her, she was actually really upset about it. She's not happy with appearance. She went for treatment. She went through orthodontic treatment trying to improve that. And she does not meet her expectation. So based on that history, I can make a informed decision that this patient is really a highly aesthetic kind of patient, that she really wants something good for her teeth to make her feel confident so that she can move forward with her life without worrying about this. So just by having a conversation about that, we can draw all these ideas and how this patient wants her teeth to look like and what the expectations are. Okay, so just more towards dentistry right now, more towards my side or dental side point of view. These are just clinical photos. I like to keep them so they can give me a rough record when I'm designing her smile in the future. When I'm doing her treatment planning. So with the photos as well, I can do a smile analysis. So briefly, I've talked about the gaps, the discolorization, and to go further, there are actually 2 points that I like to point out in smile analysis. I only do this if the patient is really concerned about the appearance, so I can speak to her before I even start the treatment and tell her what can be expected in the future or what can we improve right now. So there are two main points I like to point out, which in smile analysis would be the hard tissue aesthetics and the soft tissue aesthetics. So first of all, I can see that this is a low smile line patient. We say low smile line because the soft tissue is not exposed. It's actually low to moderate smile line, where the edges of the incisor, I'm using my pointer to show, it actually follows the lip line, but the soft tissue is not showing. And then the soft tissue, you can see there's little gaps between the teeth because of the shapes of the teeth that is not uniform. And then the buccal corridors is not really showing. I know that in social media these days, they always produce like a Hollywood smile where they take all this into consideration. And I think we can actually incorporate that into our treatment plan as well, not only for the celebrities alike, but we can try to achieve this for our patient that comes in. So moving forward, these are just more clinical photos. One is a retracted point of view when the patient is in bite, and the occlusal wheels here on the right of the upper and lower teeth. So we're just going to discuss a bit more about the clinical findings because we cannot really examine the patient. I'm just going to explain what I can see right here. So first thing I can see is the first 2-1. According to her history, she fell down, had a filling done. You can see there's a little gap between the margin and the tooth here. The laterals, the shapes are a bit rounded, the edges are a bit rounded, maybe a bit smaller. So we're going to talk about that as well, and that will might cause the ununiformity of a smile. And the lower incisor as well, there's a little gaps. Moving on to the posterior side, you can see there's a permanent retainer right here, and a little gingival inflammation right between the permanent retainer because it's harder to clean there as well. So she might have a little bit of a gum problem right there. And then in general point of view, she has a good oral hygiene, I would say, a very satisfactory oral hygiene. And most of her teeth are not having caries or any pathological findings as well. Soft tissue looks all right, no worries about that. And so from this point of view, we can already deduce that this patient wants something to improve her aesthetics. How we can achieve that is actually running through my mind when I'm doing the examination as well. That she done her ortho, try to improve, does not work for her, and what can we further improve for that? And besides that, she has good oral hygiene and she's cleaning her teeth very well. There's no caries, there's no periodontal problem. So this is quite a good case to start off with an aesthetic case. So come down to the diagnosis. Just going to talk about the diagnosis that I listed out in the beginning and all that slides that I've given to. It comes down to localized gingivitis on 1-1 and 2-1, especially on the palatal region. And for the other diagnosis will be a discolored 2-1 with a suboptimal filling and disproportionate anterior teeth. I wouldn't say that as a diagnosis, but that would be a clinical finding. I just want to reinforce what I found. And for the orthodontic point of view, this is class 3 incisor malocclusion with generalized spacing in the anterior teeth. So this is actually what I do for all my patients. So I like to list down what they perceive on their problem and what a dentist can do objectively. So she does not like a smile, multiple gaps, different colored teeth. Objectively is 2-1 is discolored with a white filling. The shapes and size of anterior teeth are not uniform. That's why she's causing the smile to be not satisfactory for her, and it's a class 3 incisor relationship as well. That's more towards the occlusal point of view, where I'm going to stabilize occlusion. So what are my goals of treatment? First of all, I want to achieve what the patient wants. That's to improve the patient's smile. I need to maintain or improve the oral hygiene, because as we know, after restoration, there's a change of the oral condition, and the patient might need to improve her cleaning before and the maintenance as well, to provide a longer stability of the restoration. And lastly, obviously, when we do any changes to the mouth, we need to provide a stable occlusion. So this slide actually pays a lot of attention to details, I would say, because we listed out all the problems the patient has, and they give us a very microscopic view, or a very a mono view of what we can improve for this patient. It's a very good idea, and I learned this during my training, that we can achieve the goals if we list out all the treatment of the goals of treatment. It might seem quite of more of a hassle to write all this, but if you do this, you can really focus on how you can move on with your treatment and the treatment sequelae. So that is done, and we're going to talk about treatment planning. Okay, so with all the clinical information that I have done and spoken to the patient, and we're going to have a discussion on what kind of restoration or what can we do for her. So as all treatments do, as she's young, the treatment considerations for this is she's young, she has practically unrestored dentition. Obviously, we want to go something more conservative. That's why I put a suggestion to re-orthodontic treatment for her. And because she was referred from orthodontic department, she told the orthodontic department that I don't want to go through another 2 or 3 years just to close my teeth, and it does not reach my expectation. And my smile is not uniform because of the shapes of my teeth. That's why she's referred to prosthodontic department. However, I still need to emphasize that you can always try to tell the patient that orthodontic treatment for this kind of cases is still ideal, because she's young. And we all know that in the future, if you do multiple restorations in maybe 10 years or 20 years, it might fail or maybe cause minor problems, and she requires a lot of maintenance. She's young. I'm going to emphasize that she's young all the time, because we don't want to destroy her future life, maybe another 50 or 60 years down the road, where she needs to do a lot of dental treatment to improve on her smile. So after having a discussion with that, she quite agreed that I want to do this. I'm going to do the cleaning very well. I'm going to maintain it very well to prolong the restoration. So we can move on to the prosthodontic point of view, where there's only 2 options in this case. There's either direct or indirect restoration. So for a direct restoration, there's only composite that can improve on her current situation. And after assessing all her tooth, it's actually quite good tooth structure on 3-3 upper anterior and lower 3-3 anterior as well. There's good bonding surfaces on those teeth, and it's going to work for this case as well. And that's more of a, I would say, less conservative method, where we're going to do the indirect restoration, veneers or crowns. There's multiple different materials that we can use to try to achieve this, and that requires further planning and more reduction of tooth structure, which is still a treatment plan, but I wouldn't recommend for this patient based on the consideration of her age and her current dental condition. So after having a conversation where I explained the advantages, disadvantages, the further maintenance of this kind of restorations, we both agreed that the composite or direct restoration is the way to go. So after having done that, I'm going to start off with my further information for my clinical or my lab situation. So I took impressions for the diagnostic casts. I did a Facebook record, and retruded axial position record, which is a centric relation of the jaw and the mandible towards the maxilla. And the reason why I need these records is I want to have something that can represent her mouth in the lab, and I can work on the lab to design her smile or design the restoration for her. So to do that, I need to mount on the any articulator and do my occlusal analysis. So occlusal analysis is similar to what we do in the mouth. However, this is done on the cast, and there is a few views that we can see because we can twist the cast around, the articulator around to see where the bite is and how we're going to design the occlusion part of it. And then based on all the information I have with the clinical photos, I will do my wax up. The wax up is done accordingly to her smile. That's why we have the clinical photos where I can design her smile based on the wax up. I need to, for a good example would be, I need to increase how many millimeters on each of the teeth, taking into consideration the material thickness and material strength, aesthetics and phonetics. Phonetics is involved if you have learned and you remember more towards dentures where if the palate is a bit too high or the palatal surface of the anterior teeth is too high, her pronunciation and speech might change. So based on that, I need to understand how much I can increase and how much I have or how much restorative space I have to restore these teeth. So obviously I'm going to follow the wax up according to the golden proportions. That would be the ideal smile that I want to provide for this highly aesthetic patient. And the context between the teeth when it's on bite and on mandibular movements, on protrusive or lateral movements, because I want to provide a good occlusal stability for this patient. So after having all that information done, I've done the wax up, I call the patient back again for a mock-up. Mock-up is just an appointment where I transfer my wax up. I'm using an index, the shapes of the teeth that I've done and what I design on the cast, and I transfer that into the mouth using a temporary resin or a temporary bridge material. And based on that, I can check how it looks like on the patient, what are the shapes and sizes, how it looks like, what are the contacts, just to reconfirm what I've done in the cast in the patient's mouth. Besides that, you also give a very good idea on how it might look in the patient and how the patient likes that shape and sizes as well. And you further can have a discussion on that to improve on the wax up if she doesn't like it, or if she's very happy with it, and we can proceed with the treatment. So in every prosthodontic point of view, we like to work towards a N, which is the end game or where we want to work towards to, and that's our goal. So with this, I would say the master idea on where we want to work to, that's really good basic necessity or idea on how we can move towards that idea. So she's happy with the mock-up, happy with the speech, good shape, good sizes, and we agreed to proceed with treatment. Yeah, so to manage the 2-1, which is this color as well, I managed to do a tooth whitening just to improve on the shade compatibility between other teeth. And I waited after a month or 2 months so that the shade can settle down, and I'm going to use my composite to try to mask it. So there are a few techniques that are present in composite restoration. There is first the freehand, where you just eyeball it, try to freehand, which I didn't do in this case because I have a wax up and it's for multiple teeth, so I don't think that's feasible in this case. The palatal shell technique is I'm going to transfer the palatal surfaces of other teeth on my cast and place it in the mouth, just to create like a little barrier between my restoration and the teeth, so I can slowly freehand and build up the anterior teeth and incisor edges or the interproximal edges of this piece. Lastly, the injection mold technique, which I pretty like to do, and there's a video showing what is an injection mold technique. However, this video is only shows on single teeth. I have to do multiple teeth, so I have to modify the technique just a little bit. So let's look at the video right here. I'm just going to play.
show you all. What you got? A billion could never buy. Oh, we're gonna party like it's 30-12 tonight. I wanna show you all the finer things you like. So just forget about the world, we're young tonight. I'm coming for ya, I'm coming for ya. 'Cause all I need is a beauty and a beat who can make my life complete. It's all about you. When the music makes you move, baby, do it like you do. Yeah.
Yep, so that's the video, and as you can notice, he's only done one single teeth. I did have to do multiple. So if you this video is actually just found off of the internet based on the company that done it, which is GC. They created a very, I would say, easier technique to restore, quite simple, and it provides quite a good aesthetic as well. I would say if you notice, their index is transparent. The reason why it needs to be transparent is actually when you're doing the injection mold technique, you want to see the composite flow. And the next thing is you want to have your light cure to go to penetrate the index so it can cure the composite. So you can just find out this technique is actually quite good, and I learned this technique in the UK, and I think in Malaysia they are moving on with this technique as well in certain cases. Okay, so moving on, this is the treatment outcome. You can see on the left side, that is the before treatment, and that is on the right side is the after treatment. You can see the composite blends really well. It follows a smile line. Here's a closer up smile for her. I would say it's quite a good result. The shape and sizes are more uniform. It's a bit wider to cover the spaces. Her midline is a bit changed as well, more towards the left-hand side. I tried my best to mimic it or to mask it, but maybe it's a bit off by 0.5 millimeters. Overall, I think it's quite good. Shade is perfect. She's really happy with it. And if you notice, she's smiling a bit more on the right-hand side, and she's even getting a better angle on it because she's so happy regarding it. And this is the retracted point of view. I've done the upper 6 and lower 6 as well. 3 to 3. And it actually produced quite a good result. The shade matching of the 2-1 is really good. Can't really see that there's a slight discoloration after the tooth whitening. However, there is a slight calculus build-up here, right on the lower anteriors. So before even starting the treatment, I have actually told the patient that because we're changing her teeth shapes and sizes, the cleansability of the teeth might change, so she might need to improve on the cleaning of her teeth. So we're moving on to the next slide. I like to do a reflection after my treatment. So did I achieve my goals of treatment? So yes, I did improve the patient's smile. She's really happy with it, and she's really grateful that we've done this treatment for her. Next would be maintain or improve oral hygiene status. So in this case, there is not an improvement on that because she had new teeth placed, new shapes of teeth placed in, and she needs to improve on the cleaning of the lower central incisor. And I did provide a stable occlusion, as you can see in the previous slide. Everything's in bite. I checked the lateral protrusive movements and protrusive movements. It's very stable. There's more contacts on the posterior teeth. So we'll consider this treatment and consider a success. And after restoring all the teeth, I put her on a periodic maintenance and review just to make sure that my composite doesn't fail, or and the periodontal condition only can improve and not be bad. Okay. One point I like to say out is in every treatment before we begin, it's always nice to tell the what ifs. meaning that what can happen if I do a composite per se? What are the failures of it? Fracture, discolorization, maybe a complete deborn of that restoration. So if you tell the patient beforehand of what might happen, it wouldn't be an excuse when it happens. So the patient will trust you more, and they will think that you know what you're doing, and that you create a very good relationship or rapport with the patient. So that's a very good point to remember. So moving on to our second case, which I would say is a moderate kind of prosthodontic case. So a brief history about this patient. I wouldn't be going to detail about more about all these cases. I'm going to go really quick on what I did in this kind of case. So we can see that he has very severe tooth wear on the upper anterior. On this left-hand side here, the central incisors, lateral canines are really weared off. There's a filling right on the upper right canine, missing teeth on the posterior teeth, and a little bit of tooth wear on the lower anterior teeth. High frenal attachment here. Upon opening a bit wider when there's free space, I just want to see how much restorative space I can have to improve on this patient's condition. So I had a chat with this patient again in the beginning. He's a 40, 50-year-old male, had this condition over 10 years, worsened over the time, and went to his dentist. Dentist tried to prevent it. So this is where we need to apply our knowledge roughly. I'm going to very briefly on this case because it's a very, I would say, complex case. We need to discuss a lot about it. This patient had a lot of fizzy drinks, and we know that fizzy drinks such as Coke, Sprite, carbonated drinks, or acidic drinks like juices will actually increase the wear rate of his teeth. So I asked him, like, do you grind your teeth? Do you know that you have subconscious grinding while you're driving or sleeping? Or what might aggravate this tooth wear to be this condition? So he told to me, like, yeah, he liked to have fizzy drinks, wine, and orange juice in the morning. And he likes to grind his teeth when he's driving. So that aggravated his factor. So I told him about the risks and how to prevent this from worsening. So I need to stop the pathological condition that this patient might have to come to this condition. So after solving all the patient's management part of view of it, I say, like, okay, we're going to move forward with our restoration, and what can we do for you, and what is your expectation, and what you expect after treatment. So he told me he wants to improve his smile again. I'm not having any pain on these teeth. I have no problem eating or anything like that. But I don't really like the appearance of my front teeth. It's really short and it's really sharp at the edges as well. So moving forward, I'm just jumping through the assessment part of it because that's a big topic to talk about there. I'm going to go straight to the diagnosis. So during my periodontal examination, this patient has good gingival health. And if you notice the one, I took an x-ray about it as well. Sorry, I don't have it right now. But it's root canal filled. It's asymptomatic and is root canal well done, and there's no pathology on the parabuccal tissue as well. So I would consider that into my treatment plan. So I wouldn't need to redo that root canal if there's any pathology. So for the prosthodontic point of view, you can see there's localized loss of vertical dimension and generalized mild to moderate tooth wear. The moderate tooth wear would be more towards the upper anteriors, and mild would be the lower anteriors. Partially edentulous mandible because he's missing lower back teeth. And this is not a diagnosis, but it's more of a clinical finding. I just place it there, so we will help in our conversation or discussion right now. He has high frenal attachment, so we can just have a look here. And the reason why I put this here is because if I'm doing a restoration, I'm taking into consideration I need to close the gap, and that's a very wide gap. It's actually 8 millimeter, I would say, based on the picture, and we need to increase the mesial surfaces of 2 incisors just to close that gap. So I like to go to this treatment planning stage again, where I list out all the goals, challenges, and patient problems. So it's all listed there. He feels his front teeth is short. He doesn't like his smile because of the short tooth wear, etc. And the challenges of treatment will be there is insufficient space, restorative space anteriorly, and there is a discolored 1-1 and a high labial femur attachment as well. These are the challenges that I need to tackle to improve, to get my goals of treatment. It's similar as before: improve the patient smile, maintain or improve the oral hygiene status. In this case, is really good, and provide a stable occlusion. So coming towards the treatment planning, it's going to go really fast on this because I think time is running out. Orthodontic treatment in this case, where the orthodontist can redistribute the spaces, either by extruding or intruding the teeth to create more space for my fillings or my restoration. And I've spoken about the patient regarding this, and he said, I don't want to go through orthodontic treatment so I can improve my smile. I'm already 55 years old. I don't want to wear the metal braces and for 2 years to try to improve on this. And so I offered him another restorative method using prosthodontic principles. It can either be direct or indirect, and for the anterior teeth to improve his smile, and a removable option or a fixed option for his missing teeth. It's either by implants or dentures. So as usual, I need to plan my case. I take all the required records for my lab study, and I did a wax up accordingly to the smile and how I'm going to do that. So in this case, because I don't have enough restorative space anteriorly, I need to create space. So there are a few ways that we can create space. The most common one that we do is when we're doing a crown, you cut the teeth to create space for your restoration. In this case, it's not feasible because it's just really short teeth. So to create that, I need to increase the vertical dimension, or I might have created some space when I'm restoring in centric relation. So I decided to go with an increased vertical dimension by at least 4 mils, so we can create more space for my restoration. And I did a mock-up, have a discussion with the patient, advantage, disadvantage, what might happen in the future. All that must be covered before I even move on to my treatment. So we agreed upon he doesn't want to restore his missing teeth, he just wants to improve on the upper front teeth. This is a treatment that I've completed. This is actually a principle that we've done in prosthodontics. It's called Dow's principle, or relative axial tooth movement, where there is intrusion and extrusion of the teeth to provide a more stable occlusion for the patient throughout the years. Because as we know, if there is a gap between the teeth will always want to come into contact. So this principle actually uses that, where I restore the upper front teeth in the increased vertical dimension and leave a gap at the posterior teeth. We like to call this reorganize his occlusion in increased vertical dimension, and we want to expect what might happen in the future. So we came to the decision that it's going to be 2 direct restorations on the canines, which are composites, and preparation of the incisors for crowns. So you can see in this picture on the right-hand side here, this is actually a provisional restoration. It's actually link provisional restoration because it's made out of resin, it's not really strong. And you can see there's all contacts here to provide a stable occlusion. And Dow's technique actually uses the anterior to have contacts and to wait for the back teeth to come into contact. So I'm just saying this, as you can see on the right-hand side here, there's at least a 2 millimeter gap right here, or a 1.5, we can't really determine, to see where is the current situation of that patient. Unfortunately, I don't have his final treatment or during a fit of his crowns. However, I have a review after a year. So this is what it looked like after a year. You can't see the bite right now. I have that in the slide, but it's quite happy. He's smiling a bit better as well. The teeth length and appearance improved. I'm going to go to the next slide and see what I did not achieve or during my reflection. So in the upper feature here is a retracted view. You can see that there's a little black triangle here. So before even starting this treatment here, I told the patient you have high femur attachment, you want to go for surgery to improve that so I can close up the space better. He didn't want any surgery. So I said, I'll do my best to try to cover, but this is always a risk. So after 1 year, you can see there's a little 0.5 gap here. He doesn't really mind it, so I'm quite happy to move forward with it. And the composites on the canines, you can see there's a slight discolorization already. I told him we can polish it, try to improve the color, but he said it gives more character and it's more happy and looks more natural. So I'm quite happy to move on with that. So moving on with the Dow's principle, after a year, you can see on this picture here, it's coming slightly into contact. He said it's biting a bit better on the left-hand side here and on the, on the right-hand side of the patient and the left-hand side right here. So before even starting this kind of treatment, I like to emphasize that when we do Dow's movement, you wouldn't have contact at the back. Your chewing efficiency might decrease, but it will improve over time. And as if we come to a point where you're not happy with the efficiency of it, we can do something just to restore it. So the concept of Dow's principle is because his teeth at the back are quite virgin, I would say, or maybe not restored on the few teeth. We don't want to touch it. We don't want to put any restoration on it because we know every restoration will have a failure in the future, and we want to keep natural dentition as long as possible. So the patient understands that, he's really accepting of it. He understands what he got into, and he's generally quite happy with this point of view. And he has an option to improve on that if he doesn't like it in maybe another 2 years. So moving on to goals of treatment, improve facial smile, yes, he's really happy with it. Maintain oral hygiene or improve oral hygiene status. During reviews, I like to check the periodontal condition. He's cleaning really well, no pockets or no abnormal calculus in this region, fairly good oral hygiene status. And I did provide a stable occlusion. He's really happy, he's biting well, eating well, did not lose weight. So further on with the treatment, as I said before, I came back after my postgrad training. So the Edinburgh Dental Institute is still going to monitor his posterior teeth and to suggest for further intervention if he wants. Upon reflection, I can see that my treatment has 2 flaws, which is the black triangles on the 1-1. The patient doesn't really mind about it, and it improves on its function as well. And there's a slight discoloration on 1-3 and 2-1. So after every treatment, you have to have that principle or I would say guide to improve on what can you do in the future. So I always do reflections after all my treatment. So that is just a moderate prosthodontic case, I would say. And lastly, I'm gonna show you my 3rd case. This is even gonna be a shorter kind of case because time is running out. Actually, this was my first major long case when doing my training. So on the first glance, you can see like what's going on in this patient. Did he neglect his teeth to be this condition? And you don't know where to start, basically. You think about, oh no, how I'm going to do this to improve this patient's smile? What are the steps? What can I start, or where do I begin? So as you notice in every of my presentation of discussion on the first 2 cases, we always start with the assessment, diagnosis, treatment planning, treatment execution, and maintenance. This is because we always get confused in between treatment. And treatment like this, it took 2.5 years for me because we have to wait for healing, wait for improvement on the bite, whether the patient can accept the new vertical dimension. So if you have a guide on that, and I'm quite sure all prosthodontists will say that we need to have the end in mind, we need to have a plan, and you need to have a control of the plan. So we always have a checklist on what we're going to do and how we're going to improve on that. So I wouldn't go too much on this case. First thing I can see is 2-1, there's maybe a fractured crown repose because the access is so big. I reconfirm it with a radiograph. You can see there's a post-space preparation, try to improve on that. Multiple restorations on composite, discolored, fractured, tooth wear on all or most of his teeth, and that's where I come into my play on how I'm going to tackle this case. Obviously, I had a conversation with this patient. He said doesn't like his smile. I can't bite properly. I'm not eating well. I'm a salesman and I really need to have a good teeth. And I even crack a joke with him, like, thank God there's COVID right now. I mean, I treated this patient in 2020, so there's COVID pandemic right now. You have to wear a mask so people can't really see that. And he was actually quite happy with that and said, like, yeah, we're going to try to improve on your smile, and I'm quite sure you'll be happy regarding that. So moving forward, this is his occlusal wheels. There's nothing much to say regarding this. Restorations is the same. Reconfirm your heavily weared out teeth, maybe half or more of that teeth gone. So I just list out the points that I'm going to do, and I really plan out this case really well, really took my time and decide on how I'm going to sequelate the treatment as well. So in brief, we decided to make space. I need to make space for my restoration. I need to choose the teeth that can be safe and cannot be safe. I need to improve on his periodontal condition because I want to build my restorations on good solid foundations. I assess all each teeth for the restorability, whether I can do composites for bonding, or if I want to do indirect restoration, how much tooth structure I left and how can I improve on that. So all the techniques and skills that I have in my arsenal would have to be used on this case to try to improve and get the perfect restoration for him. So we decided on multiple crowns and indirect restoration on his anterior teeth. He's not too concerned about his posterior teeth, and he wants something that can improve his smile and function. So I went for the concept of the shortened dental arch, where there's contact from premolar to premolar, where he has that, and using dowel to make the posterior teeth come into contact. The reason why we came down to this decision is because when I told this patient, as you can see on this picture, he has heavily restored posterior teeth. I told him that if I remove all this restoration, there might be a chance that you need to root canal, multiple appointments to try to save that. What are the risk advantages? And he just didn't want to take that risk on the back teeth. And he just wanted to do something on his front teeth in this current situation. So having agreed on that, I did my treatment planning, did my records, photos, planning on the cast in the mouth, did my mock-up, patient's happy, we're going to proceed with that. And came to a decision that I'm going to do a mix of direct and indirect restoration for this patient. So on the next slide, I'm just going to do it for a comparison. On the left side here, we can see his current, his before treatment, and this is after treatment. These are provisional restorations where I prepare all the front crowns and 2 of the posterior premolar teeth on the back teeth, and composites on all the lower anterior. If you can see, I increased the vertical dimension. That's why his smile has a little bit changed. His midline is still a little bit off, but I can't really do much because you can see here there's a 2 or 3 millimeter difference. Obviously, my picture is not that ideal. There's a bit of a gap here and some bleeding around the areas after cementing my provisionals. This is because it's hard to control cementing a, this is actually a long unit temporary bridge from 5 to 5, link crowns or bridge. And you can see that's very hard to control the gingiva. When you cement it on, the provisional cement just pushes the gums and it starts bleeding. I know that people might say link crowns are not good. However, this is a provisional, and I make sure that some small interdental brush can go in between there just to improve on its cleaning as well. On the picture on the left hand side here, you can see I use index to plan my preparation of teeth. This is because these are wet down teeth and it's not virgin teeth that we're restoring. So I don't want to over prepare the teeth. So in this case, the index actually guides my preparation here according to what material I wanted to use. So based on this picture, I can see I maybe didn't remove the palatal sharpness of this edge a little bit more and maybe improve on the margins on these teeth as well. So it's actually a very good guide on how I can improve my preparation of each singular teeth. Oops. Okay, so this is the before and after treatment of this case. Replaced all his teeth with crowns. And the first thing I noticed is I still can't correct the midline. And beforehand, I told the patient that, yeah, if I want to correct the midline, the teeth on all the sides wouldn't be symmetrical. The reason for his smile to be slightly different as well is because I numb him up for the cementation, and I think the numbness hasn't gone away while I was taking this picture. And I don't have a review picture of this patient. Next thing I can notice as well, the restoration on the back part here, the color is a bit different, if you notice, from all the restorations. However, it matches the lowest. This is the communication within the lab and me. I don't understand why they want to make my shade in the anterior teeth a bit darker and a bit brighter at the back. So I spoke to the patient before cementing. He said like, yeah, this is quite good. I'm quite happy with this result compared to my previous photos. So I don't want to wait another month for this to be fabricated. So let's just get on with it, and I cemented them on. So he's really happy with his current treatment. I have no complaints as well. And as usual, I told him to maintain his teeth, go to his dentist, just to review on all these restorations, because crowns have a lifespan of, I would say, success rate up to 90% in 5 years and around 70% up to 10 years. However, if you clean them well and you go for regular checkups and we can detect a problem early, it shouldn't be a problem, and we can last a bit longer for you as well. And I told him about the smile at the back and the posterior teeth, and anytime that you don't like it, you can come back and we can do a restoration for you just to try to improve on that, because we already created space, and even your dentist can do that right now, and it's quite easy for you. So he's quite happy with the result. I'm really happy. He gave me a present when I left Edinburgh, because it took me 2 years to treat, and I've been seeing him every 2 months, and we create a very good relationship with the patient as well. And he's very happy. He even told me that because now the treatment is done and the pandemic is over, he said like, yeah, you've done it just on time. I don't need to wear my mask. I can show off my new smile right now. So he's really happy with me. In the UK, they like to give presents after treatment and during Christmas. And I don't know why that he gave me a lot of liquor, like a lot of whiskey, and I just really enjoy it. And maybe I look like a alcoholic, but he just keep on giving me liquor, so I'm not sure about that. So he's a really nice patient, and I'm still following up with my junior postgrads in Edinburgh to make sure that he's well taken care of, and that's how I create a relationship with him as well. So that's about it. This is just a summary of my presentation. I like to emphasize these few points, and if the clinical point of view, we can always learn and practice, but these are the points that I want to pass on to all future dentists or dentists right now. Is first, we need to understand the patient, what they perceive, what they want, create a rapport, make sure that you are a friend with them, and they will compromise on treatment, and they have a very honest discussion with you and what can you do for them, and they'll be very happy throughout the treatment. Next point I like to say is always explain the what ifs and what mights, because if it happens, it's going to be an excuse. And if you tell them beforehand, they were more accepting of it. And this just reinforced to create a rapport with the patient. Next thing is have a wide skill set and knowledge on the skills in dentistry. What I've done is actually really what a GP can do, but I organize it in such a way and are more detailed in my treatment planning. So what a pros does is we have a wider skill set, we have knowledge of each and every treatment that we can do, and we know how to use them and when to use them. The point I want to say is that we need to optimize every restoration to the best that it can be, and we have to know all these skills and what can be done for the patient. So that concludes my talk for today. I think I ran a little bit off, maybe just 3 or 4 minutes. And just to end it on a good note, I'm quite sure everyone knows the Royal College of Edinburgh. It's quite a famous thing, and I had managed to have a look at it for 3 years. And every time I walk past it, I'm like, wow, that is the goal that I have since I became a dentist. And actually, I'm here right now. So that's my email. And you can contact me to have any questions or any doubts that you can ask me. And if I have time, and I'll get back to you as soon as possible. I don't mind helping another fellow dentist out, colleague, regarding this. And if not, we can always work together to try to achieve the best for your patient or even for my patient. So thank you very much. And that concludes my presentation. Thank you.
Thank you, Doctor, for the amazing presentation. I personally find it very interesting, and especially the case studies, and you made it sound easy to understand, even at my level as a year 3 student. So I'm sure that our senior will be able to appreciate more.
Thank you so much. I try my best to, because I need to know the target audience per se, so I try to make it more understandable. But thank you so much.
Yeah, again, thank you for the informative contents. So yeah, because we are running late, so let's just jump right into the Q&A session and see how many questions we can attend. Okay.
Should I end my slideshow or?
You can leave it that way, or you can end it. It's up to you.
Okay,
Yeah.
Okay.
Okay. So let's start with the first question coming from an anonymous participant. Doctor, what is the highlight of your prosthodontics career, and how would you compare prosthodontics to other specialists?
That's a very good question. Personally, I feel that all specialty have their own good point of view, because that's what their interests are. And what all specialists does is they are very detailed in their field. For example, maybe a periodontist, they are really detailed about the gums and how the body reacts to any pathology or any healing, and what can be achieved, or how can I improve on that situation. They are more towards the gum stages, and that is to me, that's the essence of any dental patients, because in Malaysia, I think periodontal condition is really bad. People just lose teeth and they don't want to do anything about it because of the high commitment, and they just remove the teeth. And we know that as the replacement guys like pros like us, if you remove that teeth, I know that natural dentition is always better. And if I can do an implant, it's a high-risk patient. He doesn't want to take care of his teeth, so I don't want to further destroy his teeth. So we always need to go towards the main point first and move on. I can further do that with orthodontists. They are one of the amazing people in dentistry. They actually move teeth around naturally. So that's a really good friend of mine that I like. I don't need to replace teeth, and I can just plan to improve on the smile of the patient if there's a microdontia case, like in my first case in that instance. So what I can say is prosthodontics is an improved version of a general dental practitioner. You can see our techniques or our skill set is similar, but we organize it, we change it, and we understand occlusion a bit better. So that is the difference. And I like to tell all my colleagues that what a newly prosthodontist or newly grad prosthodontist is a 20-year experienced dentist which is interested in dentistry. Because if you're interested in a topic, you'll be practicing it, you'll be studying about it, and then you can attempt all these techniques, because it's all published online right now and all in journals. So if you have the knowledge, you have the confidence to do it, then you can move over with it. And what postgrad does is we cram all the knowledge in 3 years. So that's what I feel personally, in my opinion.
Okay, thank you for answering that question. So it's all about job satisfactions and whatnot. Yeah. Coming up next on the list, how would you compare the enthusiasm and interest of dental graduates in pursuing prosthodontics in Malaysia versus in the UK? It's also from an anonymous participant.
Sorry, can you repeat that question? Compare the interest of pros in Malaysia
and the graduate in pursuing prosthodontics in Malaysia versus in the UK.
I think Malaysia don't really appreciate pros that much, especially the older generations, because these mono specialties, perio, pros, and endo, they used to be under restorative. So the older generation, they don't appreciate this specialty as much. However, I can see the younger dentists, like in PIDC itself, I think the most postgrads that pursue pros most undergrads graduates from PIDC pursue pros. There are at least like 6 or 7 of us right now, I'm not mistaken. Comparatively to ortho, ortho is always a famous specialty. Perio is none. Maybe there's only 2, 3. But pros is up there, so I'm pretty surprised why everyone's doing pros as well. However, it's nice because I think there is a point to be taken. It's getting there. People like to do pros more in Malaysia, and compared to the UK, because the UK runs on a different kind of system, where if there is a problem with a full mouth case or a really complex bridge or really complex restoration for the patient to restore the function per se, they know when to refer, and the prosthodontics will get those kind of cases and they can manage it well. In Malaysia, they don't really appreciate that right now because all the general dentists, they can practice and do that as well, so they wouldn't want to refer it up. Maybe in the future we can move towards working together. That's one of my aims to do, is try to change Malaysia to working together rather than giving away your patient and not having it back. So that is a challenge for all Malaysian dentists per se right now. So hopefully that answers the question. I'm not quite sure whether that answers it.
Yeah, hopefully Doctor answer your questions, whoever asked the questions. So the third question would be also from an anonymous attendee. People are shy. Okay, and good afternoon, Dr. Brian. Thank you for the very informative sessions. May I know if there's any tips on providing the most suitable treatment planning to our patients? Yeah.
So tips. I would say, like in my summary, you have to have a good skill set, what knowledge, and how you're gonna tackle that problem per se. That's the first thing that you need to know. You need to widen your scope of knowledge. The reason why I'm saying this is because right after you come out from dentistry, you're still quite a young dentist. You don't have a wide skill set and you only have that one option. However, in dentistry, there's many options that you can do. It's just that you don't practice or you don't know that skill. If you learn that skill and you know how to tackle and you know how to do it well, that would give you the best chance to provide a good treatment for the patient. Next, I emphasize again, rapport with the patient, talk to the patient, what they want, what they perceive, get as much information from them, try to understand them, and you provide your best treatment. Honesty, that's really good because patients will actually understand what you're doing and whether they think you're cheating them their money because you're doing it for the sake of doing it, or you're really trying to help them. Especially in my field, prosthodontics, we're doing a lot of treatment, so we really need to create a rapport for the patient because the cost is high. And I'm quite sure if you meet a person for the first time, you don't want to give them 1,000, nonetheless 20,000, right? So you really need to create that good relationship, and the mock-up is important as well. Show them what can be achieved. So these are the little tips that can be done.
Okay, thank you. So take notes, everyone. Always listen to your patients. Fourth questions. A question coming from Chiho, my batchmate.
Okay.
Hi, doctor. I know this is not really prosthodontics related, but I think a lot of us would love to know that how did you fund your postgrad studies and any scholarship or loans we should be aware about?
Oh, okay. I think yesterday we talked about it briefly, right? So I funded my postgrad personally, self-funded, and so we are lucky to be dentists. I was lucky enough to do a lot of endo in my postgrad and in my undergraduate level when I was learning, and I was doing when I was in the government as well, I was posted with a resto specialist, so I was doing a lot of endo, and my skill set of endo was pretty good. The reason why I'm saying this because endodontics actually pay quite a lot, maybe 1,500, 2,000 per teeth, and if you work hard for it, I worked a good 4 years, 5 years before doing my postgrad and decide it's time to go. So I actually covered quite a lot of my personal fees from working, and you cannot cover it all because it's really expensive, and I had to take parents funded as well for part of it. To me, as we are dentists, there's always scholarships available. You can go through the government route, which is the KKM route or Ministry of Health route, or you can go through the Army route is higher chance because less dentists in the army. And you can always try to apply the HLP, which is the Hadiah scholarship from the government. I forgot what's the full term, HLP, Hadiah Latihan Perkhidmatan, yeah. Which they provide to you after you provide a good number of service and you qualify to apply for that scholarship. Besides that, there's always privately funded scholarships, which is either by banks or private companies. You can find out about it. There is a Commonwealth scholarship, but that's only for a year. So you really need to prove that you're doing really well, and maybe they give you some leeway to provide you for a good 3 years or 4 years. For other scholarships, there is the education side. Sorry, I forgot the education side from Malaysia as well. You can join as a lecturer and the university will send you up. I'm not quite sure whether private universities are doing that, but the local universities are doing that quite frequently. Next thing will be the Mara scholarship. But that's only for Bumiputra, and I don't think it's called a scholarship, but more towards a loan. But it's considered a scholarship because they pay less back in the future, and that's a scheme for the Bumiputra. So you can always go towards that. So all scholarships are a bit harder to get because you don't want someone that you don't know. You're just meeting them for the first time, as I said before, and they're giving you maybe $500,000 or more than $1 million. So you need to prove your worth. You need to do interviews, exams, and try to convince them why you are suitable for the scholarship. So there's all these routes that you can go through.
Thank you, Doctor. So it's 12:15. Let's try with one last question.
Okay.
Taking the privilege of being the moderator, the next question is actually coming from me.
Okay.
So, Doctor, in your opinion, what are the current impacts of digital technology in prosthodontics? Because I'm aware that there's lots of advanced technology out there.
Yeah. So I'm always interested in IT and technology. You know, I was younger, I played a lot of computer games. I learned about IT and how amazing that is. So to me, the technology is there, but it's not used in dentistry right now. Because if you think about it, F1, major engineering, major construction, they are all using digital technology right now. And currently, maybe the past 5 to 6 years, they're incorporating it into dentistry. Especially in prosthodontics, everything is, in very simple layman terms, is you have a teeth, I'm building something over it. How can I build it? Can I use technology? So every dental technique is evolved from somewhere else. Nothing comes from us. That's the problem. Everything comes from somewhere else. Like even implants is come from an orthopedic surgeon where they build titanium bodies into the bones. And then this guy, an orthopedic, said like, why not we use it as teeth to replace teeth? So for digital, every time it's evolving, the world is changing really quickly. I'm quite interested in that. So my research is about digital as well. It's about improving each and every step of your prosthodontic treatment. A good example is from taking a elastomeric impression or a silicone impression. You can do a scan right now. So in every prosthodontic treatment, there's so many steps. So I'm not sure whether I should say this, but it's better for you to understand. There's so many steps in prosthodontics. To make a crown, you prep, take an impression, you pour the cast, you create a die. Die is for casting to create the crown, or if it's metal ceramic, or you mill it. So there are many steps, and we are trying to reduce that error in between all steps. Because in every step, there's definitely an error, but we're going to reduce it to get as accurately as possible. So to modify that, they actually evolve the classic or traditional way of impression. Instead of taking an impression, they do a scan. So an intraoral scan of impression needs to be accurate as the impression. And what are the problems with it? So they're still evolving right now. What is the speed? How the workflow is? These are all taken into consideration during a digital improvement of a certain procedure. So, and another thing is when you do the cast, because I'm sorry, I'm prof, so I have to say this, okay? So you pour the cast, the gypsum actually expands and contracts, right? So that's one of the error. So to counteract that, in the problem in digital dentistry on scanners, whenever you take a scan, they're stitching each images together to create a video, okay, if that makes sense. And then they use a software algorithm to stitch them all together into a 3D file. So as you can think that the algorithm making all this, transferring this, sticking all the images together, there definitely will be an error in between. So I would say both have their pros and cons. But I think in the future, definitely digital dentistry is going to be there. Maybe not so soon in Malaysia. In the United States, they're really going for it right now. UK not so much, because the treatment is still considered free or very little and subsidized by the government like us. So, and the cost of investing into all these digital materials are really pricey as well. So it's the future. It's not perfect yet, but it's usable. Yeah.
So it's the future, but it's not really foreseeable future, at least in Malaysia.
Yeah, they're pushing for it. If you notice, they're really pushing for it. Certain companies, certain big dental clinics, they're doing it. They say, I do digital dentistry, especially implants. I'm doing surgical guides, implants, crowns, etc., etc. But I think they need to tone it down a bit, because if they do, I understand the return on investment on implants is a bit higher. So the best thing is you incorporate digital dentistry into it so you can get back your investment. But that will cause, there's pros and cons to it. The cons part I can think is people will just extract teeth, place implant, extract teeth, place implant, without even trying to save it. So that's a good part of digital dentistry and evolving the whole structure of dentistry in Malaysia.
Thank you, Doctor, for the great insight. And again, due to the limited time, we are unable to attend all the questions live. So Ms. Kritika will be taking over for the outro, and that's all from me. Thank you, Dr. Brian and the participant, for a meaningful Saturday.
Yeah, okay, thank you, Krishan. Thank you, Kritika. Thank you. Have a nice day. Bye.
Have a great weekend, everyone. So however, like because of this time constraint, we couldn't address all the questions. So we will post the answers on our Instagram page, PIDC Virtual Circle. So do follow us on Instagram. Again, PIDC Virtual Circle. We create interesting contents, host webinars, and organize activities regularly. So yeah, that's all from my part. Have a beautiful weekend, Doctor, and everyone.
Thank you so much. Bye.
Thank you.